If you pay somebody to walk up and down the stairs, they'll walk up and down quite a number of stairs. If you pay them to get to the second floor, they'll take the elevator.
Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Very happy to be sitting here today with the wonderful Dr. Richard Frank. Dr. Frank is currently the Chief Medical Officer for a very successful company called Vida Health. And Dr. Frank has gone through many stops along his journey to becoming an industry cool guy at Vida Health. Been at a bunch of companies, seen mergers, acquisitions. A lot has happened in your journey thus far, and so excited to hear all about it. Dr. Frank, thank you for sitting with us today.
Well, it's great to be here, Mendel. I appreciate the invite, and I'm looking forward to the conversation.
So, as we kind of talked about a little earlier, we're gonna try to make this as meaningful a conversation as possible. But just to give some context, I'm still gonna fall back on some old habits. Tell us a little bit about your upbringing and what drew you to healthcare.
Well, I grew up in southeastern Michigan. Had a family that was oriented towards healthcare.
How so?
Always liked science. Always fantasized I would take care of very sick patients. I would be the hero with the gloves and the white coat running in to rescue the desperately ill patient. I went to college and medical school at the University of Michigan and did residency in anesthesia. Ultimately became a cardiovascular anesthesiologist. I was at Stanford, then the Cleveland Clinic, and then came back to Michigan. Ran a small outpatient practice, picked up a master's in public health, and then thought I wanted to take care of more than one person at a time. I thought, what can I do on a bigger scale? And so the idea of moving into the administrative side of medicine was very exciting. And after practicing for about a decade, I went to work for United Healthcare as a market medical director, then went to work for a regional health plan as a chief medical officer, spent the bulk of my career at Anthem, both on the payer side and the provider side, and then moved into the private equity world. The company I worked for before Vida was MyNexus, a home healthcare benefits management company that was private equity backed, ultimately sold in 2021, and then landed at Vida, where I'm the chief medical officer responsible for clinical strategy.
And how many patients are you guys at Vida?
Boy, we've probably touched over 2 million lives at this point.
Wow, that's amazing. So going back to the beginning, you said you mentioned that your family was very healthcare oriented, and you kind of fantasized about being a savior, a patient savior with the white gloves and the white coat. Is there any particular stories around that? Like what made your family healthcare oriented, and what formed that?
Well, I think my mother was a frustrated physician, as you can imagine. I have enough gray hair, and so you then imagine the age of my mother when she was growing up. It was more difficult, I think, for women to enter healthcare when she was a young woman and thinking about what she wanted to do. So I think to some extent there was always a bit of frustration on the part of my mother of wanting to be a healthcare delivery person, professional,
Okay.
and not being able to do that.
Okay.
And so my eldest sister is an anesthesiologist. My next older sister is a clinical psychologist, and then I'm an anesthesiologist. And so there was just sort of a healthcare vibe in the family as I was growing up.
Huh.
And one of the things my father always said about healthcare is if you become a doctor, you'll never be poor. The world always needs doctors.
He didn't know AI was coming out, right?
He didn't know AI was coming out.
I'm joking. And what did your father do?
He was a salesman.
Wow.
He sold shipping crates. And my mother was a nursery school teacher.
Wow. Interesting. She wanted to be some sort of clinical staff member or doctor.
I think so.
Very interesting.
Yeah.
Wow. So you get out of medical school and you're working as an anesthesiologist, correct?
Yes.
Something was eating at you that you needed to do something bigger. What were you bored? My understanding is there's very long shifts. There's not a lot of time to be bored. What was eating at you?
I think it was an opera. So I would frequently joke that when you would see a patient as an anesthesiologist, no patient ever wanted to hear with a PowerPoint, I have this new way of doing an anesthetic. We've never done it this way before, but I bet it's going to give us a better outcome than what you've had in the
Right.
past. Most patients want to hear that your doctor has done the same thing 10,000 times and it goes perfectly every
Yep.
time. So I would not in any way say it was boring, and many times it was quite challenging. But what I would say was there was a certain lack of opportunity for creativeness, and that was something I was very interested in. And that coupled with, I think, a deep interest in just the business aspects of healthcare, the public policy aspects of healthcare, and really a desire to touch more lives than you can in a typical clinical practice.
Now, my understanding, correct me if I'm wrong, my understanding is that anesthesiology is actually a very sought after specialty today. There's a shortage of, I mean, besides the general shortage of clinical staff, but it seems like anesthesiologists are a little bit more rare. Is that true or not at all?
Boy, to be very honest with you, Mendel, I am so far out of the clinical world. It has been probably 16 or 17 years since I've delivered direct patient
Fair
care.
enough.
But I always loved being an anesthesiologist. There was something else calling to me, but I always loved being an anesthesiologist. And the opportunity to take care of a patient during a very critical time of their life was an honor. It was an honor to be able to do
Fair
that.
enough. Okay, cool. So, what was your first opportunity to kind of move into almost like management or doing something a little bit one step above direct patient care?
So my first opportunity was really to be part of the Michigan State Medical Society
Okay.
and the Oakland County Medical Society. So as I was transitioning from delivering direct patient care into the administrative world, my first foray was really into organized medicine, thinking about how I could help physicians help patients. So in the early 2000s, I was the president of the County Medical Society. I was on the board of the State Medical Society. And that allowed me to gain a greater sense of where I, as a physician, sat in the healthcare milieu, the healthcare environment. Because many of us who go through training, especially very academic training, and then immediately launch into private practice, we don't always understand the where we sit in the healthcare ecosystem.
Yep.
I mean, healthcare is a $2 trillion business, and oftentimes we're a single practitioner or a practitioner in a group, and we don't know what's happening outside of our
Yeah.
walls. And so, just gaining access for several years to the county and state medical society and really understanding how healthcare worked in Michigan, which was where I'm located, where I was located, uh, started to set my path forward about what I might do. I actually didn't know a lot about healthcare other than how to be a
Right.
doctor. Like you can know how to be a doctor and not know anything about the healthcare system.
Yeah.
And so this coupled with a public health degree really sort of flushed out my understanding of how healthcare works in the United States.
Interesting. And you hear that a lot from doctors where like they go to medical school and they learn how to treat patients and then they come out of medical school and if they get a job then that's fine, but if they try doing anything remotely independent or anything that assumes a good deal of the actual management responsibility of healthcare, they start learning very fast that they didn't really learn about like accounting and business and just a lot of the. So were there any particularly shocking gaps as you moved into that role that you were like, wow, I did not know any of this? Was there anything that really stood out?
Yeah, I think there was one episode in particular. So when I came back to Michigan and started practicing in private practice, I suddenly became aware in a way that I had never been before as a practicing private practice physician in a fee for service financial relationship that I only got paid for what I did. If I didn't do, if I didn't deliver an anesthetic, I didn't get paid.
Right.
If I delivered an anesthetic, I got paid. Prior to that, I was always salaried.
Mm,
So I was disconnected from the financial transaction of the patient care I was delivering.
Interesting.
And I remember the day where, because I didn't think a patient was ready for surgery, I canceled the case. And then I thought, and this was very early on when I took over my own practice. So I was just getting started. Money was tight. And I just remember thinking that day, I'm not going to get paid for this case. And I had never, ever had that thought before. And it was eye opening. It was eye opening.
And so obviously that's actually a fantastic segue, because the theme of this podcast is obviously value-based care. We're the number one podcast in value-based care. And to many people, it seems very like a very complicated concept. But I mean, you just said like the realization of what fee for service does to patient care, and it essentially incentivizes you it incentivizes the patient being sick, and it incentivizes the physician having all those questions, like second guessing yourself, like, could I have done the surgery? Should I maybe have done it? So like, once that started eating at you, what was, I assume value-based care at that point wasn't a big buzz, was it?
I would say that at that point, I had no concept of value-based care. And while I suddenly became aware of as you said, the incentives, I think it's important to say that those incentives tend to operate at the margins, that for the most part, 99% of your day, you never think about the patient and the incremental income that an individual patient can generate.
Mm-hmm.
But at the margins, I think you're right. It changes the functioning of healthcare when ultimately you're paid for making widgets. And the more widgets you make, the more money you make.
Yep.
If you pay somebody to walk up and down the stairs, they'll walk up and down quite a number of stairs. If you pay them to get to the second floor, they'll take the elevator.
Whoa!
So,
great line. Great line.
yes.
Yeah.
Yes. So I don't mean to suggest that I or my colleagues operate on a daily basis thinking about, I'm going to make more money if I just do more. But I do think at the margins, it does influence the way the healthcare system works. And that was a pivotal moment for my personal development. But then what I realized, picking up some formal training in public health, was this kind of, how did we get here as a healthcare system? Why are we designed this way? What aspects of the regulatory system, the legal system, and to your point earlier, sort of the business aspects of healthcare, just accounting, organizational structure, all of those other elements, how do they fit into a $2 trillion industry of which physicians are a part, but in some ways not the biggest part? There are other players in the healthcare industry that are actually bigger pieces of the total $2 trillion,
Such
if
as?
not north of $2 trillion. So it was my own experience. It was like, I get paid for what I do. I didn't appreciate that. And then subsequently, the formal training and understanding how the system works that laid the path for entering managed care.
You mentioned that there's bigger pieces than the physician in the healthcare market. Many physicians don't like hearing that. No, but you're absolutely correct. What are some of those bigger pieces in your view?
Well, there's no small player called the Center for Medicare and Medicaid Services that basically pays for roughly 60% of all healthcare in the United States. Yep. There's no small purchaser called employers, who tend to pay for close to the next 40% of healthcare in the United States. And then from the healthcare delivery system, there's this little piece called hospitals that tend to take a tremendous amount of the healthcare dollar. And then physicians and all the other direct clinical providers. And then, sitting at the edges, you've got the pharmaceutical industry, the biotech industry, all the device makers. And then there's all the many, many individuals, Vida Health, your podcast, that make money off of that very complicated system.
Yeah.
And try to add value to it, but also count on it for its income.
Yep. Yeah. No, that was a good breakdown. So At what point did you go? So did you go from private practice to United Healthcare?
Yes, pretty much. It was actually Kevin Kelly, who is the executive director of the Michigan State Medical Society, who introduced me to a recruiter for United Healthcare. And in 2005, I started to make my transition to that company. I started part-time and continued my clinical practice, and then subsequently gave up my clinical practice and moved to United Healthcare as a full-time employee in the mid 2000s, and that thus began my managed care career.
That must have been a tough decision. What played into the decision to leave private practice?
That was a very tough decision. That was a very difficult decision. Um, I think it was, I had always, while I had entered into medicine, loved science, loved the idea of taking care of patients, I always wanted to see how I might be successful in more of a business environment. And to your point, I think earlier in the discussion, I was a really well-trained physician, but that was it. Like I was a very specialized technician.
Yeah.
I was a cardiovascular anesthesiologist. I mean, I wasn't going to be able to go get it. I couldn't even get a job. Well, they didn't exist then at the Apple Genius Bar,
Right.
but I could get a job being a very highly trained technician as an anesthesiologist. So I think it was this idea of I want to try something different and see if I can be successful.
Hmm.
And so I took the leap. It was a big leap.
But you're also going from unilateral decision making in running your own practice to a role in a mammoth, gigantic company. And I know some other people that have done that, even sold and then did that. And it's a very big culture shock to go from unilateral decision making and feeling empowered to that extent to just like being part of this structured red tape organization where people get offended if you don't write the Mr. before their first you know what I mean, and like you have to follow all the what was that culture shock like for you?
That was enormous. I started my training all over again.
Wow.
I started my training all over again. And it took years before I figured out, I think, to how to be truly effective in that kind of an environment. I think it's Malcolm Gladwell who says 10,000 hours.
Yep.
And if that's the case, it was probably 5 years and numerous setbacks culturally as I learned my way around that environment and how to be successful in it. I can remember one of my early bosses, because I sort of had this idea that all of my ideas were brilliant. All of my ideas as this new person in this new industry were brilliant. And I would keep sending him emails, and he finally looked at me and he said, "Listen, Rich, I really," and he was a physician and he was my boss in a managed care environment. And he said, I really appreciate your enthusiasm, but you don't need to send me 5 emails a day. Oh, okay. All right. Good.
Ouch.
And I had numerous people who both intentionally and unintentionally and kindly and perhaps not so kindly mentored me and helped me sort of course correct over the course of my career. And I'm grateful to every single one of them. Sometimes it was hard and sometimes it was easy. And sometimes I walked away with tears in my eyes. Oh my God, I'm a failure. But yeah, it was a challenge in a way that medical school and residency was not. It was very much a different challenge.
I mean, you already we'll start talking about the next couple stops on your journey, but I think already you can kind of see a theme. Overachiever maybe is the wrong word, but you seem to have a constant need to grow. Not just success from like a monetary perspective, but like seems like there's a certain inner part of you that needs to continue to learn new things and move up in levels and not just be content with mastering that first, all right, so I'm going to go to medical school. Cool. My parents weren't able to, my mother wanted to, she wasn't able to. I got that done. Then no, I'm not just going to become a doctor. I'm going to become a super specialized, cardiovascular anesthesiologist. Okay, done. All right. I just have a job. Let me run a practice. And then going from running a practice to moving up into United Healthcare, which is, the largest healthcare organization in the country, I believe, right? I think so.
Yep. Yes.
And then you didn't stop there. So, looking back, here's my question to you. Looking back, was it a healthy push to continue to grow, or did it come from, like, was it going somewhere, running from, or running away? Do you know what I mean? Like, or was it always changing up and always trying the next thing because you couldn't sit still?
Oh boy, that's probably 7 years of psychoanalysis. Where's Freud when you need him? Is it running to or running from to be? It's probably both. I was definitely looking for something that would be challenging in a way that clinical medicine was not. I was looking for something to test my ability, and this is looking back. I don't know that I would have framed it this way at the
Yeah.
time, but to demonstrate sort of a level of creativity. Could I be successful in an environment, in a different type of uh, marketplace of ideas?
Mm-hmm.
Could I be successful in that? And there was a certain element, I think, earlier in my professional career where, to your point, I probably tried to do things simply because they were. I did things simply because they were challenging in my professional career. What would be the most challenging type of specialty? What would take care of the sickest patients? What would be the most challenging environment? So I think there was a certain element of trying to prove something to myself, um, and maybe that's part of it. That's one of the drivers. But then I think once I became aware of this other aspect of healthcare, um, and the industrial side of it, sort of the administrative side of it, and the idea that I could change outcomes for populations, that seemed to fit. Um, and I'll say parenthetically, as I was thinking about career transitions, I tell many young doctors who reach out to me about career transitions, I actually did professional counseling around career. I did career counseling over a summer before I entered my graduate program, really thinking about, so what is it that would make me happy in my career, and what do I want to do? And oftentimes when I have young physicians who come and say, I'd like to change my career, what advice would you have for me? I tell them to do due diligence
Mm-hmm.
around what kind of career would make them happy. So I hadn't done that as I was entering medical school. You sort of go from college, oh, I guess I'll go to medical
Right.
school, I guess I'll go to residency. I didn't have a lot of guidance in that stage of my career, but as I was transitioning from clinical medicine to administrative medicine, I stepped back and actually did a level of due diligence around what would make me happy that I hadn't done before.
Hmm.
So I would say that the process, while might have some psychodynamics behind it that you alluded to, I definitely did the due diligence. And where I landed, I've actually I've been re- I was I'm very happy with the transition I made from clinical medicine to administrative medicine.
Yeah. And while the practical advice that you just gave for young doctors about doing due diligence is super important, I'll tell you, the only reason why I was comfortable asking that question is because of where you've landed. Typically, I think people that are making those transitions from in an unhealthy way, it usually doesn't work out. And it would seem to me that what you said is absolutely, with knowing you very minimally, it would seem to me that what you just said is absolutely correct, and that once you found that meaning in being able to affect populations, it seems like you've really hooked into that, and so that's kind of like what maybe possibly what you were searching for. um, and then also, there's two types of people. This is like a thought that's baking in my head right now, so it might not come out well, but there's two types of people. One type of person, um, what they do is like the actual job that they're doing is who they are, and there's another type of person that the job that they're doing is an expression or a result of the person that they are. And so if you're a person that is constantly, looking to grow and looking to evolve, then and that's your interest and that's who you are, then the thing that you're doing today is just an expression of that need to continuously evolve. Maybe that was, I don't know if that made any sense.
I understand what you're saying. It's sort of the is history the man or is history the moment? And I would say that or woman. I would say that it's really a combination. I wanted to move into something that would have a more global impact. At the time when I was making my career transition, I had two job offers on the table. One was a part-time job for United, and the other was to be the vice president of medical affairs for a small hospital. I don't even remember where, but I would have had to have moved. And I went to a mentor at the time and described the two jobs. And at the time, I didn't know enough about the way the healthcare industry worked to really understand the pros and the cons. But after much discussion with my mentor, they suggested that the outwardly looking role of a medical director for a large managed care payer in the United States would probably fit my personality more closely than the role that would be typically associated with a hospital administrator. And so that was a key moment where I diverged.
Mm,
So but I had two choices, and it was who I was. So it was both what was available to me as well as who was I that ultimately set me on my path. So had I gone with the hospital, I would probably have a completely different role at this stage of my career. But because I went with one of the largest payers in the United States and was lucky and thrilled to have that position, it set me on a managed care career that ultimately has exposed me to value-based care in a deep way that has me sitting in front of Mendel on his value-based care podcast.
right, right. So let's start digging into that. So at what point and where were you working that you started really looking around and saying, wow, I can not just I went from affecting a single patient to a number of patients, to a patient panel, up to, at what point did it become, hey, I can do things and make decisions that can actually affect the outcomes of populations, and really have an impact at a much larger level? Where in your journey was that?
I think it was at every place along my managed care journey, because you alluded to this earlier. At the margins, how we pay for healthcare impacts the healthcare that's being delivered.
Yep.
And so, as we think about where physicians sit inside managed care and how those physicians can impact both the way the care is paid for, as well as some of the individual decisions that are made for individual patients, we can actually affect the outcomes for both individuals as well as large populations. So, more explicitly, physicians sit inside policy making arms inside of large managed care organizations. Physicians, as you are sensitive to, engage in utilization management around individual patient decisions. Physicians work on the network side on how are contracts designed with both physicians and other providers. Physicians work in quality and really can assess uh, whether or not various indicators of high quality care are being met. So I would say at every stop along my managed care journey as a physician, I realized I could influence the individual decisions that were occurring in the marketplace, as well as very large decisions that affect beneficiaries across multiple geographies.
Hmm. So you spent a good amount of time at a company named Anthem. Talk to us about that. Why was that interesting to you? And you were there a while.
So Anthem is one of the largest healthcare payers in the United States. It was a great place to be. I met really wonderful people. The company is a wonderful company. It was my first, I think, senior leadership position in a very, very large organization. I had previously been at large organizations, but the combination of a senior position in a very large organization was really a tremendous opportunity to enhance the care, learn the system, enhance the care for hundreds of thousands of individuals. Think about how I interacted with the healthcare system. Um, it was just a tremendous opportunity, and I spent the bulk of my career there.
Yeah. And so from the payer side, it was a totally different window into operations and probably healthcare.
Uh, oh well, I mean, I had been in managed care by that time 7, 8 years. So I came to that organization really with a lot of experience in it. And I understood by that time how the healthcare system, I think I understood by that time. I guess I'd achieved the Malcolm Gladwell 10,000 hours. But by that time, um, I think I understood how networks of clinicians and physicians and providers are created. I understood a bit about how money moved around the system to pay for healthcare. I understood about a little bit about clinical policy and how that affected clinical outcomes. So it was really just an opportunity to practice what I had learned inside of an environment that was just presented tremendous opportunities.
Nice. So let's move on to Vida. What is Vida Health?
So Vida Health, very lucky to be at Vida. I'm the chief medical officer. We are an integrated virtual clinical program that treats patients with cardiometabolic syndromes. So overweight, obesity, prediabetes, diabetes, hypertension, hyperlipidemia, congestive heart failure, COPD,
Yep.
as well as behavioral health conditions, depression and anxiety. We do that through an app-enabled service that includes both virtual care as well as in-person care, but in-person in a virtual setting. So we have the app and we have face-to-face care. Our providers consist of coaches, certified diabetic educators, registered dietitians, nurse practitioners, physicians, endocrinologists, physical therapists, and we take risk in a value-based environment to improve cardiometabolic outcomes. I think what's so exciting about it is it's a scalable intervention
Mm-hmm.
that can be deployed in all 50 states and yet still be personalized to treat individuals who are struggling with cardiometabolic syndrome.
Hmm. And from the patient perspective, what is it like? Is it who pays for it?
So typically it's paid for by employers or insurance
Mm-hmm.
companies. So we will treat all lines of business, commercial, exchange, Medicare Advantage, Medicaid. That's on the payer side. But on the employer side, small group employer, mid-size, and then jumbo employers we provide services for. So it's really a full stack solution
Mm-hmm.
that can support varying types of environments where we find members and patients who struggle with primarily being overweight or struggle with obesity or diabetes or their sequelae.
And I think I remember seeing that it is a. Isn't there a certain level of risk that you guys take?
We do. We take risk on clinical outcomes.
Yeah.
Yes, we
So
do.
what does that look
So
like?
we fit nicely into a value-based arrangement.
Yes.
So, when you think about um, entities that treat patients with the kinds of disease states that we have, the
Mm-hmm.
diabetes, being overweight, obese, and their sequelae, oftentimes the outcomes can be very focused on the process of treating somebody. How many patients download the app or how many patients engage a provider. But we actually take risk on clinical outcomes. So for large customers, we will commit to both clinical outcomes as well as financial outcomes, in addition to the process outcomes around engagement, enrollment, persistency. So we make these clinical guarantees, and to the extent that we're not successful, we will repay fees. But we're very comfortable around our clinical outcomes in making guarantees to our purchasers.
So one of the largest issues with taking risk on on clinical outcomes is the fact that the ball is not in your court. You need the patient to do the things, make the different life and health choices in order to affect greater outcomes. And so how do you approach that? How do you go about that?
So, managed care hat. I come from a long line, and for some of your audience, they'll know of care management programs. And those care management programs are frequently focused around the idea of educating, enabling, and encouraging. To your point, the intervention is really focused on, can I convince the patient to do the right thing? And there are whole industries built and services built around this concept of encouraging, enabling, educating. I actually think of healthcare as being accountable for clinical outcomes. So if I'm responsible in a value-based relationship for a population of individuals, I am accountable for figuring out how to deliver better outcomes. And so philosophically, I believe that Invita in its relationships should be accountable for the clinical outcomes, as well as managed care organizations that are accountable for populations. So I don't consider it a valid response to say, well, my job is to just try to explain to the patient what they do and then cross my fingers and hope they do it. My job is to ensure that the patient does it. So it's the E's. There's the encourage, educate, enable versus ensure. And I choose the ensure path. I will ensure better clinical outcomes for my population. And for that, I will be held fiscally responsible.
I'm going to borrow something from a friend of mine, Gordon Chen, who was the chief medical officer at ChenMed.
And then, yes.
And I must have repeated this just countless times. I think it's so profound, and I'm sure you're doing something similar. But the way he said it was really well. He talked about how, because of this issue, right, that you're describing, where you actually you're taking accountability. That means that you're taking accountability for somebody else to do something different. That's what you're doing essentially. And so he said at ChenMed, they train their doctors in persuasion, and they make them experts in persuasion as much as they are experts in medicine, because you need to be able to persuade the patient and get the patient on board. And between that, maybe I like it so much because do you know Scott Adams from
Yes.
big Scott Adams guy, and he's his whole lens on life is persuasion. So that just made a lot of sense to me. I actually tried getting in touch with him to delve into this further. And you talk about how at United Health you sent someone a bunch of emails, and he said, "Do me a favor, stop." So I was sending him emails, and I had an email tracker, and I could see he's reading them, and the guy's just not responding. And so finally, he just sends me 3 words. He goes, "I don't collaborate." I'm like, whatever, dude. All right. That was before he got canceled. So who's laughing now? Scott Adams. But anyway, yeah, I think it's a tremendous thing to be able to say that you're taking risk, you're taking accountability on the patients, because again, I don't think people appreciate that what you're committing to is not printing a more colorful flyer or putting together better animation or training your people to smile. That's not what you're committing to. You're committing to affecting a different outcome in a patient. And that means everything. That means that the entire experience, all the E's that you're talking about, and everything from A to Z has to be effective. And that's a crazy thing to actually hold yourself fiscally responsible for, So I think it's huge, and clearly it's working. You guys are successful. You said you've touched over 2 million patients. And so now, do you take over the role of cardiologist for a patient, or are you a prevention piece so that you don't end up even having to go in that direction down the line?
So we see ourselves as providing preventive care, chronic care, and then we have a program that specializes in the treatment of obesity. we never think of ourselves as disintermediating any clinician in the patient's ecosystem. Rather, we think of ourselves as supporting the patient's clinical care team.
Hmm.
So, our health coaches, our certified diabetic educators, our registered dietitians can provide some of the cardiometabolic support that many primary care physicians and other specialists don't have the time or the resources to support. So, if you can imagine a patient who's on a weight loss journey, a journey of managing stress, a journey of managing anxiety or depression, or a journey of trying to engage in better habits, the healthcare system today doesn't really compensate physicians for spending time in that regard. But then there's a subset of physician patients who, even if they fully engage in a behavioral health and lifestyle intervention, won't achieve the goals that they're personally trying to achieve. They won't be able to obtain better health. And in some instances, they actually need prescribing support. And so we have a telemedicine arm inside of Vida where we can actually deploy physicians and nurse practitioners, mid levels, to not disintermediate or eliminate the primary care physician, but perhaps to backstop the primary care physician so that if there's a gap in the care that the patient is receiving, we can lean in and close that gap. So we can adjust diabetic medications, we can adjust blood pressure medicines, cholesterol medicines, we can prescribe anti-obesity medicines. And again, it's not intended to replace the patient's care team, it's intended to support the patient's
Hmm.
care team.
And do you coordinate with the patient's physician, or and
Yes, as best we can.
Mhm.
I mean, you can think about in a world where we've touched over 2 million people spread in 50 states, we might have a group of patients that have a singular physician practice, in which case Vita might be part of a, I wouldn't say day-to-day discussion, but let's say week-to-week discussion. But then there might be another instance where we're taking care of one patient who out of a physician's panel of 2,000 patients, and Vita might not come up. So when we know who the primary care physician is, we make really good faith attempts through email, fax, telephone to outreach them and let them know what we're suggesting to their patients. On our roadmap is to integrate around certain EMRs, electronic medical records.
Mhm.
But it really depends on the environment and the geography whether or not we can be integrated into practices.
Yeah, yeah, and physicians. I mean, at Proviva Health Group, we're coordinating with doctors, and it's difficult. Doctors need a lot of help, and so
Right.
um, that's fantastic. Wow. Well, let's see. You've been at Vida for about 2 years.
Yeah, 2 years, coming up on 2 years,
Yeah,
yes.
that's awesome. And so, what are you hoping to, as you continue in your career and your constant need to affect positive change on the world, which is clearly, I think, a core theme of your journey. What do you hope to affect at Vida?
So I think our vision is really to improve the care for cardiometabolic disease, diabetes, and its associated complications. So CHF, COPD is sort of at the periphery, but that fits in as well. And then to really find a sustainable solution for the treatment of obesity. We have a step therapy program that, given some of the cost associated with the newer medications, we think is a real opportunity. So there's a sort of an immediate tactical vision of really wanting to improve the lives and health outcomes for the populations that we serve. But I would say more globally, solving for some of the grand issues that healthcare still struggles with in the United States: inequity, access, cost, patient experience, helping individuals adopt better lifestyles to improve clinical outcomes. I mean, that's Vita's mission. But if you look back at the arc of my career, now we're talking 18 years ish. It's really been the arc of my career. How can I improve the clinical outcomes of large populations domestically, maybe one day internationally? That's my goal. And so the wonderful thing about Vita, because it's capitalizing on a virtual platform in all 50 states, the scale's gotten really big. and the ability to touch many, many lives in many, many geographies is an exciting interplay for what I think of personally for my career goals and what the company offers me an opportunity to do. So if, I think our CEO would like to cure diabetes, perhaps that's in the offing one day. But if I could say, if my New York Times uh, um, profile says one day, he improved the lives of the people in the United States, I will have had a successful career.
Beautiful. Amazing. Well, Dr. Richard Frank, ladies and gentlemen, if you're an employer looking to better your patients and get essentially a warranty on the outcome, then get in touch with Vida Health. And Dr. Frank, I wish you tremendous continued success in your endeavors. And once again, thank you so much for spending time today.